So, respected chairperson, Dr. Shrubi Dubey, Associate Professor, Department of Psychiatry, Pandit Jawaharlal Nehru Memorial Hospital, Medical College Hospital, Raipur, Chhattisgarh. And today's speaker, Dr. K. Raman, Professor, Department of Psychiatry, Savida Medical College Hospital, Chennai, Tamil Nadu. And today moderator, Dr. Aswad Babu, Dr. Suresh Kumar, Consultant Psychiatrist of Sneha Mindcare Hospital, Tirunelveli. My dear postgraduates and practicing psychiatrists, very good morning to all of you. I extend my warm welcome to all of you for this Evolve webinar. Indeed, it's a great privilege for us to organize this All India Evolve PG webinar. And we have been conducting this Evolve PG webinar for almost 2 years, and every fourth Sunday, we have released a book also, selected topic. We picked up and released a book called Evolve, book we have released recently. And there is a overwhelming response from the postgraduates and also from the practicing psychiatrists across India. We are also choosing the topic which is more relevant to the postgraduates. And the speaker also, this webinar is also a well-known eminent personality, and the chairperson also a senior postgraduate teachers across India. The webinar is not only beneficial for the postgraduates, but also it's useful for the practicing psychiatrists also. And I am very thankful to Dr. Shrubi Dubey and speaker Dr. Raman for accepting our invitation and join this program in spite of their very busy schedule on this Sunday. And today's speaker is Dr. Raman, and Dr. Raman is Professor Raman is from Savida Medical College, Chennai. Dr. Raman is eminent postgraduate teachers. And Dr. Raman is going to speak about the very important topic, that psychiatric emergency, and how to evaluate and manage the patients. And I hope this topic will be very useful for the postgraduates as well as to the practicing psychiatrists. Over to you, Dr. Aswat.
Thank you, sir. Very good morning to everyone here today. Welcome to the Evolve Psychiatric Lecture Series. We are honored to host participants from across the nation. Thank you for the continued support. Myself, Dr. Ashwath Babu, currently working as a consultant psychiatrist at Sneha Mindcare Hospital, Tirunelveli. I will be moderating today's session along with Dr. Suresh Kumar. First and foremost, I would like to express my sincere gratitude to our course director, Dr. C. Panneerselvan, sir, director and senior consultant at Sneha Mindcare Hospital. Thank you, sir, for giving me the opportunity to be part of this great journey. I move on to introduce our esteemed chairperson for the day, Dr. Shrubi Dubey. Dr. Shrubi Dubey, ma'am, is currently Associate Professor, Department of Psychiatry, Pandit Jawaharlal Nehru Memorial Medical College, Raipur, Chhattisgarh. She has completed her MBBS from Lata Mangeshwar Medical College and Hospital, Nasik, Maharashtra, and MD in Psychiatry from the Datta Meghe Institute of Medical Sciences, Maharashtra in the year 2010. She is actively involved in many research projects, has many publications in reputed national and international journals to her credit. We are truly honored to have you with us today, ma'am. Now I humbly request you to introduce the topic for the day, ma'am. Over to you, Dr. Shrubi Dubey, ma'am. Kindly introduce the topic for the day, ma'am. Thank you.
Thank you so much, Dr. Babu, Aswat Babu. The topic is very relevant today, and I think all the postgraduates and senior persons need a rebuttal on managing the psychiatric emergencies, and collaborating with them with medical emergencies is very important. And as my teachers always said, you should always know what to manage and how to manage, and know your limitations, what to refer. And I think the topic today does exactly the same. Thank you so much. And I'll request the speakers, esteemed speakers, to start off with the discussion.
Thank you, ma'am, for the insightful opening remarks and setting the stage for today's session. Now I request Dr. Suresh Kumar, sir, to introduce our speaker for the day. Over to you, Dr. Suresh Kumar, sir.
Yes, sir. Thank you, sir. Very good morning, everyone. I would like to introduce today's speaker, Dr. K. Raman, sir, Professor of Psychiatry, Savita Medical College and Hospital, Chennai. Sir has done his MBBS from Madurai Medical College and MD Psychiatry. His MD Psychiatry, sir has done at Kasturba Medical College, Manipal. Sir has also done his postdoctoral fellowship in Child and Adolescent Psychiatry at CMC Vellore. Sir is being the recipient of Young Psychiatrist Travel Award in Second World Congress of Asian Psychiatry in 2009. He is also being the recipient of Nilofer Award for best paper on early intervention in autism spectrum disorders. He is a honorary adjunct title of distinguished clinical tutor by Apollo Hospitals Educational Research Foundation. He is also being the postgraduate examiner for MD and DNB Psychiatry, a recipient of TNIPS Atma Young Psychiatrist Award. He is being the chairperson of Scientific Committee TNIPS 2024 and 25. He is also the speaker and chairperson in various academic forums at state, zonal, and national level. He has also published about more than 35 Scopus Index journal, and his areas of interest are like undergraduate and postgraduate medical education, school mental health, monitoring, and parenting. I would like to welcome today's speaker, Dr. K. Raman, Professor of Psychiatry, to start the webinar. Thank you.
Thank you, Dr. Suresh. Dr. Raman, sir, we welcome you, sir. You can start the presentation, sir.
Yeah. Am I audible?
Yes, sir, you are audible, sir.
Yeah, sure. Okay, so very good morning to all of you. At the outset, I would really like to thank Paneerselvam sir for this academic initiative, which he has been successfully running for the past 2 years. It has been a very useful, actually, book which they have actually released in, I think, in Ipsocon. So I'm also looking forward to future topics, and I'll encourage the postgraduates to actually join. So I sincerely thank the entire team for coordinating this session and making an academic useful initiative and venture for postgraduates and young practitioners. So I sincerely thank the chairperson and all the postgraduates who have joined. So today's topic will be on psychiatric emergencies, evaluation and management. So I'm sure like all the postgraduates who would have been actually handling emergency patients in psychiatry. So both in the ward, outpatient setting, as well as when you get a call from emergency department. So here just I'm going to give you an overview of psychiatric emergencies. How do you approach and manage? So this will be the outline of my presentation. So I'll just give an overview of the emergencies, highlight on suicide, and the second important emergency is like violence or like aggressive behavior. How do we evaluate and manage the patients with more focus on from the postgraduate perspective? And there are other emergencies which I will be actually highlighting the important points that you need to actually remember, but you have to go and just read further on the other emergencies. Because it's a very vast topic, I've just tried to make it as much comprehensive and concise as possible. So if you just look at, there is a definition for psychiatric emergencies which has been given. So it's any condition wherein, so whenever you're looking at a psychiatric disturbance, you just look at like three components. One is behavior, the thought, and the affect. So if any of the disturbance in these three components lead to a threat to existence or threat to the people in the environment, threat to self or harm to others in the environment. So that's considered as an emergency in psychiatry. So there are various ways of classifying this psychiatric emergencies. I think the major are the ones that we are actually going to actually look at today. The minor emergencies, although you will encounter in practice and in the ER. So we will be looking at like some discussion on like how to actually handle those patients in the ER. So suicide is one of the major psychiatric emergencies, followed by aggressive and violent patients. So there are medical emergencies in psychiatry, and there are psychiatric drug-related side effects which can actually present to the emergency. Delirium or altered mental status is one another emergency where our role is actually to very limited, but like it is more to look from a medical and a neurological perspective. And of course, catatonia, we will have a lot of differential diagnosis as far as psychiatry is concerned. And there are other drug-related syndromes like neuroleptic malignant syndrome, serotonin syndrome. And substance abuse, intoxication, withdrawal itself is a separate topic. So I didn't want to actually delve into that particular topic alone here because we have other topics to actually look at. So if you just broadly look at like how do we approach a psychiatric emergencies, you need to actually have this basic principle of like a simple ABC algorithm. So one is like A stands for this assessment of the level or intensity of agitated behavior. as well as the consciousness of the patient. So if you just look at these two things, if any patient is brought to an emergency, like if you just look at the patient is alert, aware, and conscious, I think that itself actually will give some clue about where we are actually proceeding to. The second alertness is also related to the alertness of the physical space. So I think whenever you're going to handle an emergency in psychiatry, you need to be aware of the physical space and the environment where you are actually dealing, whether it is a ward, whether it is an outpatient environment, or it's an emergency environment. The third, the B stands for like extremely important, that like many times the underlying medical conditions are ignored. So this is a major area that like people find it very difficult. Even as consultants, we find it very difficult when a patient is coming to convince a neurologist or a physician that like yes, it is a underlying medical condition that is actually causing a secondary psychiatric presentation, when they actually refuse to actually take patients, particularly in the area there will be a lot of conflicts between the physicians and the psychiatrists on like under whom the patient has to be admitted. So but I think we all should actually put our foot down to say that like it is important that the patient's medical condition or underlying neurological condition should be ruled out, and a clearance from them has to be obtained, and further psychiatric evaluation can always happen. So consider broad differential diagnosis, even if it is an acute presentation in an emergency, and even though if it is a psychiatric patient, to do not narrow down your actually psychiatric differential diagnosis, look at broad differential diagnosis. Triage is not exclusive only for like physical ailments. There is something called as mental health triage. There are a lot of actually triage scales as far as mental health is concerned, but I just found this triage scale is very useful. So I think this is more important for like people who are working in the emergency. Emergency physicians of every hospital, either it's a consultation license hospital, they need to be actually trained on this mental health triaging system. Each hospital can create their own actually triaging system also. So it is important that the psychiatry mental health profession should have an interaction with the ER people, so that like they don't call every acute agitated patient and they will just randomly call psychiatrists. So that will be avoided if they are actually properly educated on how to triage these patients. This is very simple scale that is available. I think like most of you will be able to easily understand. The red category is there is a clear definite danger to self or others where an urgent psychiatric referral is mandatory. Okay. So the orange category is the patients are aggressive, they are restless or agitated, and even to the extent they may be uncooperative, and they might be needing restraint. So this patient groups, like the referral is required within at least 4 hours. The psychiatrist should see this patient at least within 4 hours, whereas the ER team can actually manage during that time. Yellow category, to rule out other medical cause. So yellow category, possible danger where there is a clear psychosis or severe depression or confusion. There now we are actually bordering on to like actually psychiatric etiology. So the referral is within 24 hours. Whereas the green category is like very cooperative, but they are actually irritable. Sometimes like patient with acute anxiety or acute stress reaction, they might come in an agitated state. There they can be actually, the triage is relatively, you can actually delay. Whereas the last one is blue category, no acute distress or behavioral disturbance. They are just walking into the emergency. I think they can actually be, this is for the Western standard, but like in an Indian setup, all the cases are actually seen by psychiatrists. But we can actually modify this and propose to our consultation, like as part of the ER team, we can actually suggest how to triage our psychiatric patients, whom to be called first and whom they can actually call relatively later after evaluation. So these are the basic principles of emergency management before we're going into the emergency. So ensure that the patient has to be actually stabilized in the emergency itself, either by actually parenteral injections or rapid tranquilization, whichever works. And that is in case of violent or agitated patient. If it is an acutely suicidal patient, definitely you will ensure that like safety protocols are in place in terms of safe space for the patient. Elicit brief history and evaluation. You need to be very quick in actually eliciting history and evaluation in a patient in an emergency. You cannot be doing a detailed HOPI like we do for a long case in the ward. I think wherever there is an acute emergency, you should immediately act swiftly Choose the attender who is actually going to provide the relevant information. Avoid numerous attenders within the emergency, which will cause more chaos. And so just be very aware of like whom you should go and talk. Rule out underlying medical or neurological causes just by history and do a physical examination if the patient is amenable. But if not, at least a proper history ruling out like any recent injuries, seizures, any history of recent substance intake or drug overdosage, that should be actually ruled out from the history fast. So you can have a create a checklist also, like which can be actually executed by the postgraduate. The Department of Psychiatry can actually provide an emergency checklist, which can be circulated to the emergency physicians, as well as the postgraduates can just go and check like, okay, this is what the we have to rule out, so that like you don't have to spend more time in actually evaluating in the emergency, because where we need to act faster. Ensure self-protection wherever that you need, and patients preventing harm to themselves and to others also should be actually kept in mind. And you should also be very careful in ensuring that like adequacy of the staff. So you need to be aware of the supporting staff, like you need to be alerting them, getting all the medications available on time. So this might happen, see, in our psychiatric ward, I think this might be actually medications might be available, but in an emergency setting, like you need to really act faster to ensure that like the haloperidol or lorazepam should be actually easily available, so that like patient can be sedated there. So now we will just like move on to the first important emergency, that is like suicide. Okay, so there is whenever you are actually looking at epidemiology, always I would just recommend that like you should just look at NCRB data. Okay, so this is available. So like whenever students are actually looking at, because like suicide is one area like where we don't get the actual data. So whatever data is available is provided by the crime bureau. So you need to actually get this data from there. Okay, so almost like in 2023, there was an increase in almost by 0.3% compared to 2022. And this is almost like 470 deaths per day due to suicide. And student suicide has increased almost like it constitutes around 8.1%. And this is the suicide counts in terms of like states. Maharashtra followed by Tamil Nadu, Madhya Pradesh, Karnataka, and West Bengal. So there are various actually aspects like gender specific prevalence is given in the data. So whether urban or rural communities is given. So employed, unemployed, educational status, all these have been actually looked into the epidemiology. Can you just like type and just like mention? I'm just going to read a few statements. I'm sure most of you will be aware of these statements, but I just wanted to know whether you are aware of this. So proposed method of carrying out a design that will lead to a potentially self-injurious outcome. So what is this called? This is not the MCQ question, but I just wanted to make it interactive. So I just thought I'll just put this. Proposed method of carrying out a design that will lead to a potentially self-injurious outcome. What is this called as related to suicide? Anybody? Okay. So there is a proposed method. Oh, okay. So I think some people have just typed it as self-harm and all those things. So there is a proposed method is where, sorry, of carrying out a design that will lead to a potential. So this is called as planning. So, okay. So this is an indirect like a way of like actually mentioning about the suicide plan. So these are the terms that we need to be aware of, like when you're talking about suicide. Any interpersonal action, verbal or non-verbal, without a direct self-injurious component. What is this called as? Very good. I think somebody's mentioned suicide plans. Suicide communication, DSH. Can you be a little more specific? Okay. So for want of, okay. So this is called suicidal threat. Okay, suicidal gesture is fine, but like this is called suicidal threat. Okay, so there is no clear direct self-injurious component. Thoughts about self-harm with deliberate consideration or planning of possible techniques of causing one's own death. So this is actually suicidal ideation. So when we are actually looking at like suicide, I think like many of us like actually find it very difficult when even in the exam when we ask like, can you define a suicidal thought? Can we define a suicidal idea? Can we define a suicidal plan? I think students have to be aware of this statements and the definitions. Okay. Terminologies in suicide, there are two important terminologies that we are actually going to look at in we are looking at assessment also. One is intent, the other one is actually lethality. Suicide intent reflects the intensity of the patient's wish to die. And this is usually assessed by patient's motivation as well as the seriousness and extent of his or aim to die. So this is very important as far as psychiatric assessment is concerned for suicide. So like intent, and the second one is lethality. The lethality is objective danger to life associated with the suicide method or action. So you should be able to actually define this rather than like many of us will be aware of this when we are actually doing in clinical interviewing, but like when it comes to definition, I think it is very important. This is a rough classification which is given by the clinical practice guidelines by IJP. So self-injurious behavior is divided into actually three major categories. One is suicidal self-injurious behavior. The other one is very undetermined or miscellaneous. The last one is NSSI, so non-suicidal self-injurious behavior. Whereas the suicidal behavior is actually converted into like further classified as suicide, the suicidal attempt, and the last one is an aborted attempt. So this is how the broad classification of the suicidal behavior is actually looked into. So this is what is called aborted attempt, where the patient had an intent to die, but they stopped the attempt before physical damage occurred. Non-fatal suicidal thoughts and behaviors are further classified into, I think we just looked at suicidal ideation, suicidal plan. The suicidal attempt is like engaging in potentially self-injurious behavior, where the intent to die is the most important differentiating factor between suicidal attempt and NSSI. Parasuicide, who deliberately initiates an action of non-fatal self-injury. So that's called parasuicide. The assisted suicide is where an individual who is otherwise incapable is provided with the methods to actually commit suicide. There are various terminologies you will also come across in textbooks. It's called suicidal pact, where there is an agreement, cyber suicide, or copycat suicide. These are all some terminologies that you will actually come across. But I think these are all extremely important to actually have a look. So this is how the major difference between suicidal attempt and non-suicidal self-injury is considered. Of course, the intent component all of you will be aware of. When it comes to method also, like you will be aware of, like it will be poisoning or like jumping. Or here it is more of actually self-cuts or self-hitting or like banging or burning. Underlying trait is it is like a maladaptive coping mechanism, which is under a suicidal attempt, whereas it is more to actually desire to escape and to end life. So this is just a very simple tabular column that I found very useful actually. And the motivation is defined as like escape and the temporary relief of psychic distress in NSSI. So remember that like if you are asked like how do you actually differentiate an attempt from a non-suicidal self-injury, I think you can actually highlight one is the intent, the second one is frequency, and the third one is actually motivation. So this is just for, I'm not going to the details. I think this is very important. Like when you're actually looking at like there are various actually theories. I'm not going to the individual theories. That's for postgraduates. Please just look at all these models and theories of actually suicide. When you're actually writing theory also, this will be useful. So of course, like lot of people actually talk about only Emil Durkheim's social theories, but there are other theories I want you to actually go through so that like it will be useful when you write essays on suicide. So there are biological endophenotypes such as like a high degree of impulsivity is considered as a clinical endotype for actually suicide, and serotonin, low serotonin. I think these are all biological markers or biomarkers for suicide. This, I'm sure most of you will be aware of this, the risk factors. I think the most important thing that I want you to consider or look at is modifiable factors. So these are all highlighted in actually bold. Alcohol abuse, recent stressful life events, and particularly financial or relationship loss, impulsivity, hopelessness, access to lethal means, and anhedonia and impulsive. Like these are all the modifiable risk factors. So it is very important that like the modifiable risk factors if you identify as part of the initial risk assessment of suicide, then you will be able to actually specifically focus on these areas in your intervention plan. So when you are actually assessing risk factor for suicide, please do not actually follow the same protocol that male gender. Those things are all just are very, very important, but just like start focusing on modifiable risk factors. So like highlight on those areas so that like the future risk can be actually quantified. I think this is another area a lot of people actually ignore, that is called protective factors for suicide. I think you should be able to, if there is a dependent family relative, I think that is considered as an important protective factor for suicide. Pregnancy or motherhood, who are highly religious or spiritual, and who have positive coping skills and positive family support. So these are all the important protective factors like for suicide. So when you are assessing a suicidal patient, you should be able to actually look at these components. Many times we don't actually look at the protective factors. We just look at only past suicidal attempt, previous history of psychiatric illness, any comorbid medical illness, any terminal illness, or these are all the things that we actually generally focus. But actually, you can look at like a protective factors. So it is generally in an outpatient setting or in an emergency setting, or when the patient is actually sent as a referral, these many details are not looked into. Ideally, you should actually be able to spend quality time in evaluating a patient so that you arrive at a proper suicide intervention plan, which is individualized for that patient. Okay. So you need to be also educating family members, or even in the ward, you should be sensitizing the ward staff nurse about the possible warning signs of suicide. Okay. So like if it is behavioral, or is it verbal or psychological. So it's not only for the family members when you actually discharge the patient from the actually hospital, because the immediate risk of actually the high risk of suicide is like after discharge from the hospitalization. So you really need to psychoeducate the family members about this warning signs of suicide as part of the intervention plan. But it is not only for them. I think it is also for the duty doctor who is there in the psychiatric ward. It is also important that all the chronic medically ill patients who are actually evaluated, the physicians also should be mindful of such suicidal warning signs, because like they will be appropriately referring to us. So these are the principles of management assessment of a patient who is made a suicidal attempt. So first is like find the contributing factors, detailed psychiatric assessments when the patient is in ICU or in an acute emergency where medical treatment takes priority. I think you should just look at past psychiatric history or a known psychiatric patient. And if at all the known psychiatric patient, or like if it is under intoxication due to alcohol, then you need to actually assess for immediate withdrawal symptoms, and that should be the taking the priority, and the management plan will be sensitized towards that. So specific suicide inquiry, for which like we have what is called as actually the rating scales and the screening questionnaires. Severity of or the suicidal risk or the severity of the suicidal attempt, which is based on the intent as well as the lethality, you should come to an algorithm for management plan. Okay, so I think henceforth, if you go and see any patient in an ER or patient wherever we are going, you have to actually come to some plan. And many a times we also see that like we are not actually following patients who are referred to us like with the deliberate self-harm. There is always this tendency that like they have a personality, nothing can be done, and we just leave them. Or in our busy schedule also, we will not have enough time to actually follow them. So what is important is, I think as postgraduate residents, when you are actually in the learning phase itself, you should have an intent to follow up patients who are actually referred to you from a consultation license setting. So if you see a patient today, like ensure that the patient is actually followed up till the time of discharge, and you should have a treatment plan so that when the patient comes for medical attention for subsequently, you will be also seen. That is how we liaison with the medical team. Otherwise, the patient will come for medical management and the patient will be ignored, and they will be again coming back to us in the emergency with another attempt or a deliberate self-harm. That is when we will be redoing the work again. Okay. Most important component is like, which it is very important, we need to start from the training period, is documentation. So it is very important that like you document everything that you actually observe. Without documentation, it is going to be incomplete, and particularly in an MLC case. Suicide rating scales, I'm sure most of you are aware of this. I just wanted you to at least just go and just re-look at this Beck suicide intent scale, which you will be actually administering. And this is a simple sad person scale. I'm sure all of you are aware of this. Even as an undergraduate, you would have read about the sad person mnemonic. I think the only component that I wanted to highlight is when the score is around 3 to 4, close monitoring alone is required. So you can actually do an inpatient, ward inpatient. You can administer the sad person scale, and you can just see if you're not able to have luxury time in doing a detailed evaluation, at least just like do a simple evaluation. Something is better than nothing. So Beck suicide intent scale, I think you should evaluate and assess for the severity of the suicide. And then like you should be able to actually look at which patient require hospitalization. This is for outpatient actually can be very, very useful. Okay. This is a very simple screening questionnaire. And if yes is there to even one of that, I think you need to actually send for further suicidal evaluation. So in the past few weeks, have you ever wished you were dead? Have you ever felt that you or family member would be better off if you were dead? So these are all 5 simple screening questions, which just takes 20 seconds to administer. I think when you are actually training undergraduates or when you are actually training interns, I think you can actually sensitize them on this kind of simple screening questionnaires when you become a postgraduate teacher. So this is very important. I think like from the, again, from the same clinical practice guidelines I've picked up, risk stratification. I think you need to just identify who are at high risk, who are at moderate risk and low risk. High risk are people with psychiatric diagnosis with severe symptoms, command hallucinations and substance abuse. Moderate risk are like there are risk factors identified, but you also have some few protective factors, whereas low risk are predominantly modifiable risk factors, but strong protective factors are available. So based on that, you can actually design the intervention. So like you can actually do this process as an exercise whenever you are actually seeing patients in the future. So this is the management flow chart. So if at all you assess the imminent risk of danger, there is no danger, then just document and provide relevant treatment and monitor. If there is a danger to self, then you just decide whether the patient is out treatment is possible. If it is not possible, hospitalize and then like document all the important findings. And if it is possible, then most important thing is you will have to psych-educate the family members to restrict the means, provide relevant treatment, and then like prepare for like psychological intervention. So both pharmacological and psychological intervention wherever, and provide emergency contact numbers. And regular follow-up, it is mandatory. So the most important component is removing the means. I'm sure like this safety planning is one component which is very important, which can be actually done as like as a postgraduate, you can actually teach them. Crisis intervention and safety planning is one component that you need to actually master as part of the psychological intervention. They talk about no suicidal contract, but there is controversy on like using this no suicidal contract, verbal or written. So there is a controversy on this no suicidal contract, but I think you can actually look at safety planning as well as the crisis intervention module. So there is a plan. This is a very simple plan which is identified for actually. So identify risk factors, protective factors, make a suicidal inquiry, and assess the exact risk and stratification. Document the suicide risk level, intervention and follow. This is a 5-step plan of SAFE program. Okay, so this is how my safety plan is actually done. Okay, you will have to teach them, ask them to identify what are all the warning signs that are difficult. So say, for example, if it's an emotional sign or a behavioral sign or a cue in the environment, which is a warning sign. So I feel very anxious, I feel very distressed, and that is when I just get this thought of suicide. Things I can do to take. So distraction. So what are all the possible distractions that you can actually do? And the third one is actually internal coping strategies that you can actually try. Okay, what all you can actually try on your own, like to cope up with acute suicidal thought. Okay, and the fourth one is whom all I can actually contact at times of distress. And the last one is like medical emergency contact number. So these are the 5 things that you can actually teach them. Ask them to identify the warning signs, internal coping strategies, people or the environment with which they can actually distract themselves, a simple relaxation that they can calm themselves down. The fourth one is contact numbers of the family or friends. The last one is medical person contact. So prevention is extremely important. I'm not going into details of the psychopharmacology, but I just want to highlight two important drugs. One is lithium and clozapine. I'm sure most of you are aware that so clozapine is very effective in reducing the suicidal risk among patients with like schizophrenia, and lithium has a very good anti-suicidal effect. So, one therapy that is very, very important, and I think we have to all of us, I think as postgraduate training, I think when I did post-graduation, I think DBT was we were not aware of this DBT components, but now it is mandatory that all the PG trainees should equip themselves with the DBT component, because we are looking at a lot of personality overlay, and DSH components are actually, DSH prevalence is actually on its rise. So many times we are not able to identify the exact prevalence. So when it comes talk about suicide prevention, you don't talk about only acute stabilization management and instructions to the hospital nurse, remove all the weapons and supervised monitoring, keep the actually patient very close to the nursing bed. All these are instructions that you just do on the hospital. What you will just tell the family members, restrict the means, actually supervise the medications. So what you will tell in the emergency team, like the same what you will be actually telling to your nursing staff in the ward. So, and then this is how you will be providing instructions. But what is more important is prevention. So there's something called as gatekeeper training. I think there are a lot of modules available on gatekeeper training. Reduce access to methods is one very successful method that has been actually found to be very effective in reducing the suicidal acts and items. Media reporting, and there are a lot of preventive methods, like I will just highlight on important preventive methods: identification and easy access, education of general practitioners, making a suicidal line available. So every hospital, I think we should have a suicidal helpline. This is very important. Crisis intervention. I think all of us should be aware of the model is given by Roberts and Ottens. It's a 7-stage model. One is acute assessment. You just do it like the way what we actually do it. What are the contributing factors like for suicide? Establish rapport and engagement. That is very important. You need to establish the rapport. So the third one is what is the presenting crisis? Okay. So what is contributed to the current suicidal attempt? So that is what we are going to focus. This is what is a crisis intervention. Explore emotions and cognitive responses. Look at any distortions, look at any overwhelming emotions that we are not able to handle. If it is part of underlying emotionally unstable personality, then you really need to teach them some grounding exercises. The most important component of crisis intervention is problem solving. So you're going to teach them some alternative problem solving and adaptive coping strategies. They are using some maladaptive coping strategies. You are going to actually teach them some problem solving techniques. There are various steps on problem solving that we need to actually equip yourself. Mobilize support, or like how do they reach out for support? Pharmacological intervention wherever required. So these are the 7 stages of actually Robert and Norton's crisis intervention module. And there is a term called psychological first aid, which many people get confused about. So that is exclusively for people who are in distress, particularly when they are exposed to trauma or disaster when they come to an emergency. So if there is a victim of any disaster, there they come to this, they can be actually managed by this called the psychological first aid. Psychological first aid need not be given by a mental health professional. So it can be actually, you can train psychological first aid. There is a training manual by WHO and UNICEF. I think you can go through that. And any person, community workers can be actually trained on this. The 4 important components is safety, provide calmness and emotional stabilization, which is self-efficacy. Connectedness, which is linking survivors to actually social and professional support. Most important component is look, listen, and link. Look for what is the safety needs that are required, listen empathetically, and link them to support and resources. This is the 3 important core component of psychological first aid. I think postgraduates can also look at how do we differentiate psychological first aids from mental health first aid, and what is the difference between psychological first aid from psychological debriefing. Okay, this is the model of suicide prevention that I was going to summarize. It's a universal prevention. One is biopsychosocial components that you will. I'll give an example. So if it is universal prevention, screening for alcoholism comes under biopsychosocial component of prevention. Decrease access to alcohol and pesticide comes under environmental. And sociocultural, there are positive portrayal of women, all those things comes under the universal prevention, okay, under various biopsychosocial components. So selective component is like those who are actually vulnerable population, diagnosed psychiatric patients. So like vulnerable population, low socioeconomic status patient, chronic medically ill patients with lack of social support, indicated, targeted like population where there is an established diagnosis. So can anybody say what is this? Okay, so this is the this is a provision given for locks for farmers for holding pesticide. This is one of the very successful measure in India and to prevent actually suicide. Okay, so farmers can actually keep the pesticides and organophosphorus compounds. So this is your first question for the day. Which of the following is considered as a state-dependent suicide risk factor rather than a trait factor? I've just make it easy by giving you the choice. Very good. Pesticide bank, I'm sure. Glad. Rakesh, thank you so much. Okay. So I got some answers and very good. So most of you are right. I think the first, for this, like I think the first answer, right answer, I think people will just note down. So it is acute intoxication. The rest of them are all trait dependent. So when you're actually looking at like modifiable risk factors, I was just talking about modifiable and non-modifiable. Similarly, you should also look at like state dependent risk factor and trait dependent risk factor. Okay. So I'm sure like all the other things are all like a trait which cannot be actually so that is to end up with the actually suicide. So we'll just move on to aggression and we have almost like around 10 minutes, 10 to 15 minutes. So I'll just like try to find. So these are the risk factors for violence or aggression. So I'm sure like you should be able to look at all the medical causes which can actually precipitate agitation or aggression. So the most important thing is like we have been looking at like, a lot of people with emotional disturbance or like agitated behavior when there is a fluctuation in their like sugar levels in a known diabetic patient. So it is very important that like you need to collect a medical history properly when a patient is coming with violence or aggression. So general infections, then there are sepsis, metabolic and electrolyte imbalance. Like I think these are all the common reasons for like violent or aggressive behavior. I'm sure most of the psychiatric causes, you should be aware of it. And you can actually have it in acute situational reaction. Even people can be aggressive when they have an acute stress reaction and the survivors of sexual assault. Okay. So this is another interesting table, like how I pointed out for suicidal attempt and non-suicidal self-injury. This is basically how do you differentiate agitation if it is secondary to primary and underlying medical condition, or if it is a primary. How do you easily identify? Okay. So one important thing is, I think underlying medical condition, it is sudden onset of aggression, but if it is psychiatric, you can actually look at gradual onset. So the second important component is physical examination findings if it is there, and for attention and concentration is generally intact in a primary psychiatric disorder, and level of consciousness is usually alert. This is a simple way of actually identifying agitation secondary to this. So how do you assess? Is there any rating scale like for actually suicidal rating scale? This is one simple violence checklist. It's called Brosset violence checklist. I think there are a lot of checklists. I'll share this one, but this is a very simple violence checklist. It's called Brosset. It's present or absent, which you can actually easily administer. Okay, so there are a lot of other scales which I have actually highlighted. Do's and don'ts. I think this most of you will be aware of. But very important is like protect yourself, unarm the patient, keep the doors open, keep others near you. So this is all very simple principle in an emergency setting. That is very important that do not keep potential weapon, do not wear necklace tie, do not keep any provocative family member in there. This is very important component in the OP setting or the IP setting. Whenever you are having a provocative family member, that can actually lead to escalation of agitated behavior. Do not sit, do not confront. That is very important. So assert authority, but at the same time, do not actually give any false reassurance. This is like we had safety plan for actually suicidal attempt. We have what is called safest approach. It's called spacing, maintaining distance from the patient, Appearance, be empathetic and calm. Focus, watch for potential weapons. Exchange, engage in conversation by de-escalation. This is the most important step. Stabilization, physical and chemical restraint. Treatment, then formulate a treatment plan. That is the last step. These are all the initial steps that you will have to follow for a violent or an agitated patient. Verbal de-escalation, I think like we need to train ourselves or see our seniors actually and then role model them. Respect personal space. Be aware of the physical spaces designed for your safety. Avoid provocation. Be brief, calm, and but at the same time, actually, your tone should be like very clear and do not be in a confrontative tone. Okay, set clear boundaries and provide choice and optimism. Engage. So this is how we should actually progress. If at all the verbal de-escalation is not working, we will shift to oral management, pharmacological management. Initially, if the patient is actually amenable for oral medications, you actually give them, or else you actually convert into a parenteral medication. If parenteral medication is also not working, then you will actually combine benzodiazepine and antipsychotic. Okay, you can try in the second step parenteral medication with benzodiazepine or antipsychotic. The third step is combination of benzodiazepine and antipsychotic. So I'm sure like this is one short note in many of the like MCQ, the postgraduate papers. I think rapid tranquilization, you need to know about rapid tranquilization. What are all the medications that are actually used and what is the maximum dosage that is actually used and how frequently that you will have to actually use. So you start with oral drug, benzodiazepines, and there are a few antipsychotics. There are parenteral drug, intramuscular injection and intravenous injection. There is one drug called as loxapine, which is like inhalation format is available, but like I think we don't use that loxapine at all very regularly. So just be aware of the dosages and the onset of the action and how frequently you will have to repeat the drug. So this tabular column will just give you that. It is just from IJP 2023. I'll just share all the references. Do we use restraint? Yes, definitely we will be using restraint in some patients where we are unable to actually contain them by verbal de-escalation. We are unable to actually, they are not able to get sedated actually even for pharmacological management. Then you proceed to restraint. But most important, please have a restraint checklist and you will have to have a visual check every 15 minutes. Release a restraint every 2 hours, may reapply if needed. Neurovascular check every 2 hours. Food, water, bathroom every 2 hours. Behavioral check, MSC every half an hour. Respiratory check and change physical position every 2 hours. I think there is a mechanism of restraint procedure. I think all of you should be also aware of how to restrain a patient. The second question, a violent psychotic patient refuses medication and threatens staff. De-escalation fails. What is the next sequence of action according to emergency psychiatric principles? Okay, this is a very simple and straightforward question. I'm sure like the order is verbal de-escalation, rapid tranquilization or pharmacological management followed by restraint. Do we use seclusion? We don't use as per MHCA 2017. We are not supposed to use seclusion. Seclusion is contraindicated. Okay, so now we'll move on to the other conditions quickly. I want you to just be aware of these conditions for your exam purpose as well as for clinical purpose. Neuroleptic malignant syndrome. Okay, so I'm sure like you should be aware of this criteria. There are a lot of named criteria. I think you can look at Levinson criteria. DSM-5 criteria I've mentioned here. So request to fulfill 3 primary criteria. Okay, so exposure to the dopamine blocking agent, severe muscle rigidity and fever, and at least 2 other measures. Okay, so you need to be actually aware of at least one standard criteria in neuroleptic malignant syndrome. And there are risk factors, young people, recent increase in actually antipsychotic dosage, polypharmacy or antipsychotics. Okay, so these are all very important, or high dose of antipsychotics you start at the beginning itself. These are all some of the risk factors for neuroleptic malignant syndrome, or if there is a dehydration or any other medical comorbidity. Just look at Levinson's criteria, and this is a pharmacotherapeutic like management. So I've just like given what is the starting dose for dantrolene, bromocriptine, and amantadine. Okay, so you should be aware of this, because like when you are actually going and seeing a patient in ICU, if you're going to be a final year or a senior resident subsequently, you should be the person who will be telling the ICU team on how much dose you would require. Although the ICU team will be aware of it, but as a psychiatrist, I think you are the primary person who is in charge of this. Okay, so you can actually start with bromocriptine 2.5 milligram to 5 milligram 3 times a day, and up titrate like a 2.5 to 5 milligram every other day, so that like you can reach up to a maximum of 45 to 60 milligram. Okay, so this is the titration schedule for bromocriptine. So the next important component is emergency is lithium toxicity that you need to be aware of. So it is very important that like serum lithium monitoring is important. But do not underestimate this important finding that like sometimes serum lithium will be just mildly elevated, but you might have an impending neurocognitive toxicity that might be actually upcoming. So just every time when a patient is coming on lithium, please be aware, and do not just read this only for the theory purpose and for the exam purpose. Please apply it on the patient. Whenever a patient is on lithium, please do ask for clinical features of lithium intoxication. So if it is mild, it is 1.5 to 2.5. It is moderate, 2.5 to 3.5, and it's more than 3.5 milliequivalent per liter. So most importantly, gastrointestinal and CNS side effects. So discontinue lithium. So if it is possible, you can actually do a gastric lavage if they have come early. Otherwise, generally, more than 40 milliequivalent per liter, hemodialysis is the treatment of choice. Okay. This is another condition we don't see much, but at least you need to be aware of it. Whenever you are actually combining SSRIs, two SSRIs, two SNRIs, whenever a patient comes and says few symptoms, I think you need to be mindful of the serotonin syndrome also. There are two important criteria that you need to be looking at. One is Hunter's criteria and the second one is Sternbach's criteria. The Sternbach's criteria talks about 3 out of the 10 clinical features. I'm sure like you'll be aware of this. One is confusion, okay, agitation, myoclonus, hyperreflexia, and diaphoresis. So at least look at like these two components. One is altered mental status, clonus. Okay, you can just like see that like clonus and altered mental status with hypothermia. Okay, so these are all the 3 important clinical features of like serotonin syndrome. You need to be watchful of this, then only you can actually recognize. Discontinue the offending agent, provide supportive measures. I think cyproheptadine, you are aware of that, like cyproheptadine, but like since we are not exposed to actually this particular condition, our usage of cyproheptadine is very minimal. So just be aware of it. I've just given the loading dose also. The last one is the catatonic stupor. I think catatonia is one condition that we need to be actually aware of. We are not coming across much of like a catatonic schizophrenia. Either it just like it comes as undifferentiated schizophrenia. Dissociative catatonia or like a catatonia secondary to severe depression is one condition that we actually can look at. This is the template or flow chart. Stupor in the context of affective or conversion disorder, in the context of psychotic illness. Okay. If it is in the context of psychotic illness, please rule out NMS. Okay. So NMS, you just have to actually rule out after eliciting history. Okay. Not taking antipsychotic, NMS is ruled out. Consider second generation antipsychotic and follow benzodiazepines and ECT protocol appropriately. Whereas if it is like in the context of mood disorder or conversion disorder, go directly to the lorazepam challenge test. Okay, so you need to be aware of this lorazepam challenge test. The maximum dose of lorazepam can be tried according to the guidelines is like 8 to 24 milligram per day, but like you should be monitoring periodically for response. Okay, if at all within after 1 to 2 days there is minimal response, you can titrate up to a maximum dose, and there is not much of a response in 1 to 2 days, there is 3 to 5 days of total, then you should consider modified electroconvulsive therapy. This is again for you when you're actually going for like seeing patients in the consultation license setting, when you're called for delirium. Our role is non-pharmacological management. We will have to actually psychoeducate them, like reorient the patient and less stimulating environment. Those things have to be told to the ICU team, but be aware of the antipsychotic doses for patients with the delirium. So with haloperidol, it is like 0.25 to 0.5. Start very low and go very slow. Okay. Quetiapine 6.25 to 12.5 milligram OD. So just be mindful of the cardiac side effects when you're actually prescribing delirium. Be mindful of the anticholinergic agents if the patient is already getting, which can actually worsen delirium. The third question, a 34-year-old male with schizoaffective disorder is admitted to the ICU for extreme agitation, hypothermia, lead pipe rigidity, labile BP, tachycardia, and creatine kinase of 18,000 IU per lead. He received IM haloperidol repeatedly over the last 24 hours. Despite cooling and IV fluids, rigidity and fever persist. Trial of bromocriptine is also given, but does not improve. What intervention is likely to produce least mortality in this case? It's all been tried. Okay, Jayashri, yeah. So as per the textbook also, no, like, but many a times, like, it is all related to case series and case reports. That's why ECT has very less, not been actually looked at. But MECT has the lower least mortality. Mortality is like very less with like MECT, although we are all skeptical about actually considering MECT in a case with NMS. Okay, so we will just to just give an overview on whenever you are actually looking at emergencies, there are emergencies specific to elderly. So this tabular column, I think we have just looked at most of the things like, but I think what you will have to just look at in elderly is a particular condition called as elder abuse. There is an again topic for discussion. So you should just look at elder abuse. That's one component that we look. Elderly assessment, particularly in emergencies or this is a summary of all the elderly assessment, but I just have highlighted a last but fourth elder abuse. There is a caregiver abuse screen evaluation. It's available. Okay, so that is one thing that we can actually look at. And there's something called as confusion assessment scale in the ICU. So whenever you're actually going for delirium evaluation in a patient in ICU, you can administer this CAM, confusion assessment method, or delirium rating scale. These are the two scales that I just wanted you to be aware of. I'm sure you were aware of Bush-Francis Catatonia rating scale. This is another area that I wanted you to be aware. Who will take the patient in the emergency? Unresponsive, medically unstable, altered mental status, irrespective of medical stability, catatonia with suspected medical etiology, agitation with suspected medical etiology, irrespective of medical stability, patient requiring surgical intervention, irrespective of medical stability, primary psychiatric history, medically stable. That last one only is primarily under psychiatrist. The rest all is under physician. And psychiatrist is as only liaison. Okay. This is to summarize the emergencies in children. Just be aware that like children also present with the similar conditions like adults, but other psychosocial issues is one thing that we need to be considered, particularly in children. Like they can actually be brought by family members. Like you will have to have and watch out for Munchausen syndrome. Okay. These are the assumption tools specific to children, Columbia Teen Screen and Suicidal Ideation Screen. There is a pediatric CAM ICU. Okay, and there is a brief psychiatric BPRS. I think most of you are aware of the adult version. There is a 5 for 6 to 18 years, like you can actually use BPRS for children. Dosing in children, just be aware of the dosage. It's milligram per kg. For lorazepam, it's 0.05 and to 0.1 milligram per kg. And haloperidol, it's 0.025 to 0.085 milligram per kg. There is something called as therapeutic holding instead of physical restraint for patient children with like violent behavior or aggression. So it's just that the therapist actually holds tightly and engages in a conversation. If the child is amenable and settles down, then there is no restraint. If not, they proceed to the restraint. Okay. MHCA. MHCA section, can anybody say like what section in MHCA actually addresses psychiatric emergencies? This is not the only one question is actually the any section which is addresses psychiatric emergency. Very good. Section 94. Very good. So section 94 addresses psychiatric emergency. It is very clearly defined and MECT can be provided in emergency setting. It is false. So remember that like although an emergency management can be actually provided by a registered medical practitioner or at least actually 72 hours. In case of disaster, it can be extended up to 7 days, but an MECT cannot be given in an emergency setting. This is the question for the MCQ. Which section focuses on restraint and seclusion in MHCA? I hope no ChatGPT answers. Yeah. 97. Good. So 97 focuses on restraint and seclusion. So like this is very clear. Seclusion is banned, and restraint, even if you're actually restraining, okay. So I think you should not be used as a punishment. Those clear indications has to be very clear. Restraint monitoring has to be there. How early nominated representative should be informed of the restraint is within 24 hours. You should inform them that like we are actually restraining this patient. There is, all of you are aware of this IPC code changed into BNS 226. BNS 226 equates to 309 IPC. Okay, so can anybody say which section in MHCA talks about like decriminalization of suicide? Very good, very good. So it's 115. So that is what is decriminalization of suicide. Good. So with this, other emergencies, I think you need to be mindful of. We're not seeing much of eating disorders. You need to be also looking at like what are the criteria required for hospitalization in an eating disorder patient presents to the emergency. Panic disorder, acute stress reaction can present. Substance intoxication and withdrawal is a broad chapter. I think like you should be actually looking at what are all the withdrawal management and deception in ER. So this is like Munchausen syndrome and malingering, which can actually present to an emergency. So these are all the warning signs of abuse and neglect in children and adolescents. I'll just give the highlight the important points. Serious injuries with no trauma history, unusual injuries based on age and developmental level, high occurrence of UTIs or injuries to genitalia and rectum. Okay. Frequent injuries and seeking medical assistance for at several locations in elderly. Okay. Isolation from friends and families, and these are all for elderly. The last question. When deception is suspected in a psychiatric emergency, the best documentation practice is to label the patient as malingering, record clinician suspicion explicitly, document objective evidence, inconsistencies. Okay, Pooja is right. So you will have to document objective inconsistencies very clearly. Then only you'll be able to identify Munchausen and malingering. Okay. So with that, this is the summary. Triage, it's for elderly, but you can use it for ensuring safety, clinical stabilization, diagnostic clarification, monitor progress, deprescription. Deprescription is like remove all the drugs which are actually causing trouble, or it's called deprescribing is like itself has a lot of guidelines. Give whatever is required medications, non-pharmacological measures, monitor the progress, psychoeducate them, and deciding about the treatment setting, shifting the inpatient unit and documentation. So this will apply for every patient in emergency. So in summary of the rating scales used in emergency setting. So I'm sure like you will be aware of Barnes Akathisia scale, Bush-Francis Catatonia rating scale, and panic disorder severity rating scale, SIVA, and agitation and calmness evaluation scale. So these are all some of the scales for. So these are the references. I would strongly recommend all the PGs to just read standard textbooks, and other things that I've just taken only from clinical practice guidelines of IGP. Thank you so much.
Thank you, sir. Thank you very much for the lucid presentation, sir. The participants were very actively involved throughout the session. They are actively answering. I now request the chairperson to give her note on the presentation. Dr. Surbhi Dubey, ma'am. Over to you, Dr. Surbhi Dubey, ma'am.
Thank you so much to the guest speaker and Dr. Silvan and East West Pharma for this lovely presentation and elaborate presentation on managing psychiatric emergencies, covering the entire population right from children, elderly, and to young adults. I hope the takeaways were very informative, and the PGs will be guided, as well as senior practitioners and young practitioners like us will be benefited from sir's elaborate explanation, plus the emergency management as well, which was very nicely covered. Engaging all the and thanking all the students who participated so well and were so active during the conversation. I saw all the chats they were putting up, questions they were putting up. And I will request Dr. Aswat Babu, if we can answer a few of them, although they were being answered during the presentation, but just a few, if sir allows.
Sure, ma'am. I think almost for all the questions, sir, discuss the answers then and there, ma'am. Is there any particular question that you have to address, ma'am?
One thing I noticed that most of the times the medical emergencies and psychiatric emergencies overlap, and here the blame is being pushed on to the psychiatric medications. And how to tackle this? Because what I've seen, the PG start fighting in the emergency rooms. So just that one bit I would ask sir to point out. Rest, I think everything was covered.
Sure. Thank you,
Yeah.
ma'am, for that.
Mm.
Sir.
That was one practical, Dr. Raman.
Yes,
The
ma'am. Yes, ma'am. I
practicality.
agree with you. That is the reason I just wanted to highlight that one particular slide where I wanted to mention that, like, I think we as psychiatrists, we need to actually train our PGs to be more assertive and
Yes,
put our foot down and say that, like, if it is medical, if it is neurological, we will not actually take unless there is a medical clear. There are a lot of times, like, when actually the medical people actually deny documentation. So I will ensure, and we will actually tell the PGs to say that, like, otherwise the faculty have to talk to the emergency physicians. Still, that is a problem, and with that, like, because even the ER physicians actually, whenever a patient comes with like violent behavior, I think they don't actually even see the vitals, to be frank.
yes, yes, yes.
Yeah, they will call the psychiatry postgraduate, and the psychiatry postgraduate has to come and just like evaluate medically also. So in this
Yes.
way, I think like our postgraduates will become actually more, the medical knowledge of our postgraduates will improve. But I think it should not be overburdening us also, that like all the patients with violent behavior should be actually seen by only psychiatrists. So even like I will tell, we have come across like a patient who was becoming very agitated in the ward, and our postgraduate went and saw, and like probably subsequently when I went and saw also, no doctor has come and visited. So he started shouting. So for that, they have asked the psychiatrist to come and see, and so that like these kinds of situations happen in many licensed setting. But I think we need to put down, or there should be a very good collaboration with the ER physicians. So we are actually, I'm just also looking at like sensitizing ER physicians on, because they need a lot of actually psychiatric emergency like handling.
Yes.
They have a tender because there is an undergraduate lack of exposure, and so they don't actually take psychiatric emergencies. They say that only psychiatrists will come and see.
Yes, yes.
They should have an
Uh,
initial evaluation even for a psychiatric emergency. I just recently conducted a training for the Apollo emergency physicians where we created a checklist for them, ER physicians. And so that like they say that like we don't have time for actually elaborate questioning. So please give us a checklist. So we just created a checklist, and the ER physicians will tick that. Legal implications they will ask, suicidal aspect they will look at, and then they will call the psychiatrist. So this part we just try to work out, and it's almost like bridging the gap slowly.
that is extremely thoughtful of you, Dr. Raman. I hope you can share that checklist with us.
Definitely, ma'am.
So our work is like step. I think we can also start in our institute.
Sure,
Thank you
ma'am.
so much,
I'll
Dr.
share it,
Raman.
ma'am. Sure.
Thank you, Dr. Raman, Dr.
Yeah.
Paneerselvan, for such a engaging topic. Thank you so much.
Sir, if there are no further questions, I request Dr. Paneerselvan sir to give his comments on this, and we'll have concluding remarks.
Thank you, Dr. Aswat. Thank you, Dr. Raman, for a very wonderful, very informative presentation. Actually, psychiatric emergency is a very broad topic. Psychiatric emergency in adult and psychiatric emergency in children. So I think he has covered very nicely, covered all the things. Thank you, Dr. Raman. And more than 100 participants stayed till the end of Dr. Raman's presentations. It's a very good presentation. Thank you, Supreme Dubey, madam, for sparing your valuable time to chat the session. And I thank all my colleagues, Dr. Aswat Babu and Suresh Kumar, and all the participants for active listening and participating in the discussion also. The YouTube link is available for the current session, also in the past session. The link is available. Please contact the Eustace Pharma for more details regarding the link. And my special thanks to the sponsor, East Pharma. I conclude the session with the East Pharma. Thanks.
Thank you, Dr.
Sorry, sir, I overtook the time, and thank you so much for the opportunity, sir.
Very nice presentation, Ram.
Thank you.
It's a very nice presentation.
Thank you, sir. So, East West Pharma extend our gratitude to the speaker, as Dr. Raman sir has given a lucid presentation for the benefit of our PGs, and also we extend our gratitude to Dr. Surbhi Dubey madam. In spite of her busy schedule, she has given her inputs on this topic and setting the stage also. And also, as usual, Ashwat Babu sir and Dr. Suresh Kumar sir has set as moderators. We extend our gratitude, and we are extend our important gratitude to Dr. Pasi Paniselvan sir as consistently doing the Evolve webinar for the past 3.5 years. And all these videos we already distributed in a book format also. Next work is also started. So for the for this topic and previous topics, you can contact our Resource Pharma people for the link. Edited version is available. And from Resource Pharma, we are we are delivering our New Year wishes to all. Happy New Year to all, Doctor. And thank you so much for the program.
Thank you, Naveen. Happy New Year to all the audience, postgraduates.
Wishing you all a happy New Year, sir.
Advance Happy New Year.
Happy New Year, sir.
Thank you.
Thank you all.
Bye, Dr. Ashwath. Thank you.
Thank you, sir. Thank you so much.